Good afternoon, everyone. This is Megan Fournier. I am the Meeting and Education Coordinator with the Home Care Alliance of Massachusetts. I wanted to start off by just going over a couple of things before we begin, but thank you for calling in. I know the COPs is a big deal for everyone right now, so I'm glad that you're able to have this opportunity to listen in. You all will stay in mute only just for the sake of chaos and everything. There's a lot of people on this call today. If you do have questions, in the sidebar that you have for this webinar, there is a questions tab. You can type them in there and it will be addressed at the end of the webinar for the sake of time so we can get through the whole presentation. And then on top of that, this will be recorded, so for some reason if you have to leave early or you have other staff that you really want to listen to this, I will make it available to everyone and send it out once it's been processed. I believe that's all I have on my end, so at this point I'm going to hand it over to Arlene to introduce herself and to go along with the webinar.
Thank you so much, Melanie, and welcome everyone. This is Melanie and I were just talking before we started the event here and talking about how much is going on in our industry, and it's probably one of the most active times that I can remember in my past 35 years plus of experience in home health. Just as way of introduction for those of you who don't know me, probably some of you have seen articles I've written or attended some of my events with Decision Health, with Quality in Real Time, or with AD Maxim Consulting. But like I said, I've been doing this for a number of years now, and I started a consulting business in 1986. I am the vice chair of AHCC with Decision Health, and that's the Association for Home Care and Hospice Coding and Compliance. So I'm very active in the industry overall, particularly in compliance. So I've got a little background in this, and this is actually the first time that these conditions have changed, certainly in this dramatic fashion, other than getting OASIS added to it, since I started. So these conditions have been around for a very long time, and it's certainly time that they make that change. I'm a little surprised that they did it as suddenly as they have. I don't see anything in the near future that lets us to believe that they're going to postpone it. I do know that NOC, and I've talked to Bill Dombey, and NOC is attempting to postpone it until the first of the year, but I don't see that happening at all. So whether or not it does, we still need to get ready. So even if we have a few extra months, we might have a little more time to make the necessary adjustments in a more organized fashion. But whatever the case, we're going to have to make sure that we change the way we do business. So we're going to talk today about just opening the door to the new conditions. And of course, we can't get into all the detail that's included because there is so much involved in this. But this is going to be a good overview for you, I hope. And please feel free, like Megan said, to key in any questions that you have so that I can try to help answer those at the end. We still don't have the interpretive guidelines out, and that's a real handicap, particularly for those of us who are trying to educate agencies on how to change policies and that kind of thing. So we're all kind of doing the best we can. I have several emails out to CMS and to NOC trying to get information on whether or not they have any idea when these interpretive guidelines may be released, but I haven't had any responses as of yet. So we have a number of problems with the set the way it came out, because for those of you who remember, who were around when the initial set came out 3 years ago, we've had a lot of changes. I'm sure you'll agree with that in the past 3 years. So the comments that were made in that first period, once they were released, are 3 years old. So we've had a lot of different things coming up now, and but they made the final decision to present this to us as a final version with those old comments, and so we don't have an opportunity now to change anything. It will stand the way it is until some future date. But right now, again, we're living with comments that were made 3 years ago. One of the areas that they took away in these new conditions was the information on discharge planning. There was a very large set of discharge planning instructions. They've completely eliminated them from the conditions. And what they've said in the comments, if anyone was interested in reading that 384-page document of the conditions that were released, in the comments they indicated that they are not going to go with the home health condition discharge planning information, but they were going to rely on Impact Act discharge planning requirements. Those have not been finalized yet. The comments were in, but the Impact Act has not been finalized yet as far as issuing the decision on what we will have to have included. I do have some information on discharge planning regarding the Impact Act, and I'm happy to share that with you if you want to email me after this is over. It's very similar to what we saw with the original set of conditions, but there are some differences, and it's very integrated within with hospitals and other post-acute care provider information as far as discharge is concerned, but it's very structured. With that, I need to just say this because I'm not sure how it's all going to work out. I almost think that agencies are going to have to look at having a discharge planning department and perhaps a discharge planning manager similar to what we see in hospitals to actually be able to go along with all the requirements put in this final version of the Impact Act. So on October 14th, they released it. So that was 3 years ago. So this was the first time, like I said, in 17 years that they even did anything to revise the conditions. And that 17 years ago was very minor revisions. CMS had a maximum of 3 years for the final version that was released in 1996. And that didn't happen. There were so many other things going on. That was when that Balanced Budget Act went through, and of course we're still living with some of the fallout from that. But the home health was not on the top of their radar screen at that time. We were busy getting OASIS going and that kind of thing, so that just kind of fell by the wayside. So the 3-year requirement passed, and so they had to issue another deadline. So the experts in the industry agree this is a sea change to the conditions. This is a complete, almost a complete replacement. Some of the requirements are similar, but you'll see that some of them have significant changes in them. So the other handicap we have is that we don't have, and I've got 6 months on here, but it's not even 6 months any longer. We only have until July 13th now so this is March. Only 4 months we have to get this all together and make sure that we are ready for the requirements. Some of these will not be as difficult for agencies who have accreditation particularly through Joint Commission, because many of the requirements you'll see are very close to those requirements that Joint Commission has for their accreditation process. So again, in 1997, we thought that was going to be the big one. This was part of the REGO Act, the Reinventing Government and Balanced Budget and all that kind of thing. And the revisions that we see here, we're focusing on outcomes of care. They eliminated procedural requirements. And so what we have in the end here with the 2017 version is very similar to what we saw in 1997 with just some structural areas. So the woven theme throughout the proposed conditions is integration, communication, and coordination. And you're going to see that repeated throughout this entire set. So the structure for the 1997 proposal was they wanted the approach to be a transition toward patient outcome-based system, but at that time we didn't have anything like OASIS so that we could measure anything. We really didn't have anything conclusive that we could use so that they could actually measure outcomes. An intent to stimulate improvements in processes, outcomes of care, patient satisfaction. We didn't have anything together that would help us with that at all. That the care needed to be patient-centered, supported by patient outcomes data, and an interdisciplinary approach to the care delivery and reflecting the team approach to healthcare delivery. So what they were saying there was that they wanted to be able to measure all the data that was coming out of home health assessments. And like I said, we just didn't have a tool to support that, and I believe that was probably most of what caused this attempt to get the new conditions presented to fail. So again, this is certainly a sea change. This is going to cost us quite a bit of money. The original that came out in 2014 said it was going to cost $148 million over the first year and $142 in years 2 and thereafter. When the final rule was presented, it doubled. So they're saying it's $293.3 million the first year and then $290 million the second year and thereafter. There are going to be costs included in your revision. This is going to be an entire revamping of the way you do business in your organization. So you're going to have costs incurred that they certainly didn't allocate for when the OMB looked at this. So again, it's a huge, huge change for us. It's going to cost you money, that particularly those that pertain to the patient rights requirements. It's now required that you inform the patient with the document itself and then verbally. We have time frames for that. The language assistance services and auxiliary aids, we've had that in the conditions in the past. However, what's going to happen now is that you're going to see that these are all going to be enforced by the surveyors. And so in many states, and Massachusetts has been, the state surveyors there have been a little harder on you all, I think, than some of the other states, but they're going to actually start enforcing each one of these patient rights issues. So my other concern about this whole thing is that I believe that this is going to be where the sanctions are really going to become very visible for home care agencies, so that you may incur costs in dealing with sanctions. Of course, those can be up to $10,000 a day. So the other cost that you're going to incur that's going to be that you're going to feel is the cost for following up on all kinds of complaints. And they expect that to increase to $10,000 a year. Again, this is going to be a culture change. We're no longer going to be able to do business as usual. And I've been telling people this for years. This is really, really going to impact the way you do business. The culture change within your organization, we're going to have to start behaving more like institutions. It's not going to be as laid back as we have been in home care. Maybe that's a good term. For the past number of years, we're going to have a behavior change. Boards of directors are going to be much, much, much more involved in the day-to-day operations of your agency. Your management and your staff are going to have to change. We're going to have job description changes. Again, the functioning of your board of directors is going to change. It's going to be a long learning curve. We'd only have, like I said, 4 months to get ready for this. Now, some of you aren't going to have a survey on July 13th. I understand that, but should a surveyor show up for a complaint survey or something, you're going to have to be ready. So your staff, your management, your owners are all going to have to learn this. The other folks that are going to have to learn how to do this are the surveyors. And so that's going to be, my hunch, and I hope I'm wrong, but my hunch is that the surveyors may just overreact to some of the areas that they find that they think may be in noncompliance. And again, it might be costly in terms of sanctions. So some of the conditions have been removed, and some of these you'll be able to say, oh, yay, this is a good thing. So we're not going to have to do 60-day summaries to doctors like we have in the past. Your PAC committee will no longer be required. Now, don't stop doing your PAC meetings now. You want to make sure that you continue to do your PAC meetings through that July 13th date. Your quarterly clinical record review will go away. You won't have to have those minutes done, and you'll no longer have to have an annual program evaluation. So some of this is going to be taken, QAPI will take the place of some of this type of information. So it's not that you won't have anything to do, it's just that it'll be in another form. Your subunits are no longer going to exist. So if you have a subunit, and I've spent a lot of time in the Massachusetts area, but with a number of agencies, but I'm not sure how many of you actually have subunits. But if you have a subunit, that's something you're going to have to start working on right away. You're going to have to call your regional office and find out exactly what they want you to do with that. You will have to either become a branch or you will become a parent agency. So you won't be able to share a board of directors any longer like the subunit did. So it's going to have to be a separate entity. And so the first thing I would do if you have one of these is to call your regional office and ask how that's going to work in your state. There's language indicating that agencies will have to comply with accepted professional standards and principles. This has been reworked to reference clinical practice guidelines and professional standards specific to home health. So they, are using examples like the American Nurse Association scope and standards of practice as an example, but you'll have to, they will be looking very closely to make sure that your processes and your policies and procedures reflect some type of documented standards of practice within the organizations. Agencies aren't the only ones, again, getting ready for this big change. Your surveyors are going to have to be trained. Again, we do not have interpretive guidelines out yet. Your surveyors that are working with accrediting bodies are probably going to need less training because, like I said, much of what we're seeing here reflects what the accrediting bodies have been doing for a number of years. So your policies and procedures, even though you have them in place as an accredited agency, you're still going to want to check to make sure that you're in compliance with each one of these, even though they're similar to your accrediting body policies. So they have some principles, and I think it's good to understand these so that you understand why they're doing some of this. So their first transformation principle is the development of more continuous integrated processes across all aspects of home health. So you'll see as we go through this, there's an awful lot of integration between the disciplines that you'll have a lot more communication, not only with the disciplines, but other team members that are servicing the patient. So for instance, if you have a patient going to a wound clinic, you'll be responsible for making sure that you have communication documented within the clinical record relating to wounds. The process is based on patient-centered assessment, care planning, service delivery, quality assessment, and performance improvement. So there'll be a lot of time spent during your survey and surveys in the future looking at what you're doing to make the patient that you're seeing unique. So they want to see a unique assessment. And we've run into a problem, and I've been telling software companies this for a number of years, we've run into a problem with these software companies kind of steering your clinical activity. And what I mean by that is that you have these the software EMR notes and EMR assessment tools that are really kind of cookie cutter type of things, and so this whole set of conditions is pushing away from that. And so the software vendors are also going to have to be able to negotiate through these conditions and make sure that they're satisfying the conditions, and so the agencies aren't getting caught with having processes that don't look unique to every single patient. So they want to see a patient-centered assessment, a unique assessment to the patient. They want to see a unique plan of care. So your care planning should look different. They should be able to put down on a table 5 different plans of care, cover up the patient's name, and be able to tell which patient that plan of care belongs to. Your service delivery needs to be different. You're going to have to get your patient's request for the type of, like a DME company, for instance. What DME company? And I know that we've all said that we do that, but there will have to be documentation that indicates that's being done. And then your quality assessment and quality improvement, they'll be looking to see how that's going with every single one of your patients. To use an interdisciplinary patient-centered approach, again, you see that patient-centered, you'll see this again throughout. The approach will need to include contributions from various professionals, their interactions with each other to meet the patient's needs. So it'll be important that all team members are looking at the patient individually and coming together and meeting and documenting goals and trying to reach goals that related to the individual patient. They stress quality improvement by incorporating outcome-oriented, data-driven quality assessment, performance improvement programs specific to every single agency. They don't want to see a copy program that's copied and pasted from the internet. They want to see, you can use the internet or you can use samples from companies, but they want to see that your quality improvement program is very specific and unique to your particular agency. They take away the focus of administrative processes requirements lacking adequate consensus or evidence that they're predictive of either achieving clinically relevant outcomes for patients or preventing harmful outcomes for patients. So what they're saying here is, the bottom line is that they're getting rid of the PAC, which was really kind of a time-consuming process that didn't necessarily mean a whole lot to everyone, that the fact that you needed to have the board of directors write minutes with certain things in them at least once a year. So some of the agencies that I've been in, I know that the board of directors only shows up about once a year to sign a document saying they had a meeting. And so this is all being taken away. And so they want to make sure that everyone in the organization, all of the committees, everyone that's on your organizational chart is working toward finding patient outcomes that are unique for your agency, unique to every single patient, and that home care is really making a difference in these patients' lives. They want to safeguard patient rights. Now, we've lived with patient rights for a number of years. That first set, I believe, came out in about 1986. And it's kind of redundant, and in most agencies what happens is the staff member goes in to do start of care assessment and puts a piece of paper in front of the patient and says, these are your patient rights. Although we're supposed to read through those rights for the patient, I know that that doesn't always happen. That will no longer happen with the current conditions of participation. You will need to be very clear and very careful in examining the rights and explaining them to the patient. The other thing we have going on here is that patient rights also has to be in a language that these patients understand. So my recommendation for agencies is to look at your geographic cultural makeup and determine what they're not going to expect you to have a set of patient rights for every single language that all the patients in your area speak. But if you have some predominant areas of, I know in the Boston area you have a high number of Russian patients, so you would probably want to have a Bill of Rights in a Russian language that would be used. We have here in my area, in the Detroit area, we have a lot of Arabic and Spanish, so Spanish probably would be a routine, English and Spanish, and then whatever would be unique to your geographic condition. So that you have to explain the patient rights, writing and verbally. You're going to have to accommodate and comply with those limited English proficiency requirements, although, again, we've needed to have those for a number of years. This will now be enforced, and there will be an increase in patient rights regarding care planning. So the patient, you'll see in the patient rights, there's a lot of information about the patient's need to be involved in goal planning and actually preparing the plan of care for themselves. They want to focus on patient-centered, again, data-driven, outcome-oriented process that promotes high-quality patient care at all times for all patients. So, again, significant changes. The numbering's all different. So if you look at these conditions, you're not going to have the typical numbering that some of us have memorized. 484.10, which are patient rights now, is changing to 484.50. The subparts have changed, the definitions many times have changed, the responsibilities of the administrator. The administrator is going to have to take on a new, more expanded role in functioning within the organization. You're going to have to, in your Bill of Rights, actually give the specific name of your administrator, the business contact information, and the administrator actually will be responsible for receiving and handling complaints. So there will have to be good documentation within your organization and a process in place that you've outlined with all of your staff indicating how that's going to work and that you've got good documentation so that when the surveyor does come, they'll be able to see that the administrator is in control of the complaint process. The responsibilities of the board of directors has changed significantly. The board will be very involved in the QAPI program, and I'll go into a little more of that in just a minute, and then, as I said before, the subunits are going to be eliminated. Your branch office, we probably all know what the branch office is. They did not include mileage in here, and I know that some of you have applied for branches, in, particularly in other states. I'm not sure about Massachusetts so much, but they talk about being sufficiently close, and that many of the surveyors say, well, we want to see it within 50 miles. Well, there isn't anything in these conditions that specify that. Again, when we get the interpretive guidelines, we may see something different, but right now, the branch office will function the way it always has. Your subunit, as I mentioned, will have to be, you have to call your regional office and find out exactly what they're planning on doing with subunits if you have one. Your bylaws will no longer be required. You can use them, but you don't have to have them. And then your supervising nurse, that term that we've used for so many years is gone. They've replaced it with a term clinical manager, and that clinical manager takes on new responsibilities, and there's different definitions for that. With a clinical manager, it's going to have to be a qualified licensed physician or a registered nurse. Now, your supervising nurse was always a nurse, but now it can be a qualified licensed physician or a registered nurse must provide oversight for the patient care services and personnel. So the oversight for the clinical manager, they're going to have to oversee patient and personnel assignments, and pay attention to that, because in many agencies, and depending on the size, they assign this to clerical personnel. So the oversight, so the clinical manager is going to have to be very, very careful about overseeing those assignments, making sure that you're assigning staff that have the expertise to take care of the patient that's being seen. Coordinating patient care, making sure that all those coordination of services is complete. Coordinating referrals is another area that the clinical manager will be responsible for. Assuring that patient needs are continually assessed, so they'll be taking part in probably record review. Assuring the development, implementation, updates of an individualized plan of care. Here's another thing, if you have this printed off, you might want to highlight that. You'll see this term over and over again in this set of conditions. You have to have an individualized plan of care. They're not going to put up with these 5- and 6- and 7-page plans of care any longer. They want to see that it's individualized, that's unique to that patient. My recommendation to you is that your plan of care never gets beyond 2 pages, a page and a half at the most. And we can talk about that at a later date, but the individualized plan of care is going to be looked at very, very carefully. Assuring the development of personnel qualifications and policies. You will have to do revisions in your job descriptions for almost everyone, and also your policies and procedures in your organization are going to have to change. And so the clinical manager will be responsible for making sure that the job descriptions are being met and that your policies reflect what's actually going on in the organization. Your administrator, now this is another important one. This can be an MD, RN, or someone with an undergraduate degree and experienced in administration. So it's no longer just an RN or an MD. So just because you have a registered nurse or a medical doctor, that does not mean that they can automatically become an administrator. So they have to have experience in administration. They didn't give us the years of experience here. Again, this may come out in the interpretive guidelines. We'll get more information about this, but this changes the game here. And so some of the administrators who do not have these qualifications will be grandfathered in, but you'll have to remember that if you change positions, you may not, unless you meet these qualifications, you may not be able to function in another organization as a new hire in another home care agency. So your administrator is going to have all of these requirements. So again, I hope you can kind of see how the structure is going now to make us more like an institutional type of entity as opposed to home health, where we've just kind of been able to put people in positions that we think would work out well. Many times, you know, in my years of experience, many times I go into agencies and most of the staff are family members or cousins or friends of the family. Well, this is going to have to change. So the structure in your organization is going to have to be very, very different. So here, let's just look over. These are the brand new rights. Your patient rights with the clarification rights for every patient, the revision of the processes and conducting the patient rights violation investigations and addressing verified violations. I would expect with the changes within the patient rights, we'll see more complaint surveys based on patient rights. And you'll see, again, this being targeted very closely when the surveyors come in to review your agency. Your care planning, coordination of services and quality of care, again, incorporation of the interdisciplinary team approach. The focus is on care planning, coordination of services, quality of care processes, your QAPI program that we'll talk more about, and then infection control, prevention and control. This can be rolled into your QAPI program. You will be required to follow accepted standards of practice to prevent and control the transmission of infectious disease. They encourage you to visit the CDC website frequently. So your infection control manager will be responsible for that. Now, depending on the size of your agency, you may have to have a separate manager, an infection control manager. Like I said, this could be rolled into QAPI. And this particular person would be required to educate employees, patients, and patients' caregivers about standards. So infection control is going to become a big deal with these new rules. So let's talk a little bit about patient rights. We're going to take one of these one at a time. You're going to need to completely revise your patient rights statements. Now, some of you that are using those booklets that you can buy from some I don't know, maybe there's more than one company now that sells those. This is going to be very difficult for these companies to maintain those booklet type of things, because you're going to have copies of your admission, your discharge, and your admission, discharge and transfer policies in your booklets or your start of care packets. I'm not sure what you call them, but the information you give the patient when you start up their care. So you're going to have patient rights that are completely revised. Now, I do know that Quality in Real Time that I represent, and there are other consulting companies, are very busy in rewriting these patient rights, and so I'm sure you'll be able to purchase these. If you want to rewrite them yourselves, you need to start working on that right away, because it's going to be a big change. And when that July time frame gets closer, you're going to want to make sure you issue the new patient rights to each one of your patients that are on service at that time. So your complaints, your grievances, when they're filed, you're going to have a detailed process in place for compliance. And it's going to have to be well documented. The surveyors are going to look, when the surveyors go out to the homes to see patients, they're going to want to, they're going to ask the patient if they've had any complaints and how they were followed through. So those will have to be, that part of it will have to be rewritten. This is the first time that the surveyors regarding the complaints will actually be able to enforce every single one of these patient rights. Much of it they've kind of glossed over and they haven't spent a lot of time on. This will be the first time that they'll actually have enforcement authority. Your patient representative, you're going to need to pay attention to this. There are two types of representatives, and you'll need to educate your staff on this. One is a non-legal representative that can assist the patient in understand the information that the agency gives them. This could be a neighbor or family member. And so, again, you're going to want to make sure that your staff understand this and what the differences are, because there's time frames related to when they receive information that are different from with one and the other. They need to identify which category the patient fits in. There's several rights that don't fit each type of representative. So the notice of rights is more extensive because of this requirement, and they want a list of consumer protection agencies and language services in your contact information. It outlines the requirement that both the patient and any representative have the right to be informed of the patient rights in a language and manner the individual understands. So the rights are actually divided into 6 different categories: the notice of rights, the exercise of rights, the rights of the patient, the transfer and discharge, and then there's 2 others that didn't get on the slide. I apologize. The notice of the rights is more extensive because, again, the things such as the requirement to list the consumer protection agencies and their contact information. The agency has to provide the patient and the legal representative with the following information at the time of the initial evaluation. So you want to highlight these: the written notice of the patient's rights and responsibilities under the rule, and written documentation regarding the agency's transfer and discharge policies. Number 2, the contact information for the agency's administrator, including the name, the business address, and the business phone number for the complaints. And then the OASIS privacy notice. The information has to be understandable to persons who have limited English proficiency and accessible to individuals with disabilities. So the receipt of the notice has to be confirmed with a signature by the legal representative. Now pay attention to that. So there's a big difference between the legal representative and the patient representative. By the completion of the second skilled professional visit, the patient has to be provided with a verbal notice. So let me give you an example. If you have a nurse that does your start of care visit, they would have to be giving the patient the written documentation on patient rights. If you have a therapist that goes in that afternoon or maybe 2 days later, and that's the next skilled professional visit, that person would have to give the verbal notice. Now, I had a discussion with somebody earlier in the week about, well, couldn't you do both the written and the verbal at the time you admit the patient? And I guess the answer to that would be yes, as long as you have the time to do that. This is pretty extensive, and I think it's going to be difficult to get all of that in. But you'll have to have 2, my interpretation of this is that you're going to have 2 signatures, one that indicates that you gave them the written notice, the second signature with the time and the date that would, when they gave the verbal notice, because they have that 48-hour time frame in there. If the patient has patient-selected representative that is not present, and the patient agrees to have the representative get that information about the patient rights, now you have 4 business days to deliver that information either by mail or electronically. Now, if you do it by mail, I would recommend that you do it certified mail and have get a return receipt on that mail. So you may want to get email addresses for these representatives, but you'll have to pay attention to that. And I'm going to give you a table that I put together that you can print off, and maybe you can use that as well for your staff. With the limited English proficiency, you're going to have to compare what the conditions say with the civil rights for compliance to make sure that what you're doing now is sufficient, because you do have that responsibility now, but because of civil rights, but you want to make sure that you have everything that's necessary. The exercise of rights has been completely removed, or they removed incompetency, I'm sorry. The language replaced it with has been a judge to lack legal capacity to make healthcare decisions established by state law by a court of proper jurisdiction. So we're wondering if, with the interpretive guidelines, if they are going to actually require that we have a copy of the judge's ruling in the clinical record to show that exactly what the patient is not able to do for themselves. If the patient's been adjudged to lack the legal capacity to make the care decisions The agency needs to be aware of what the patient is allowed to exercise in his or her rights and the extent allowed by the court order. Again, this is just looking as though we're going to have a copy of it. If the patient has not been subject to such a judgment, the patient's representative can still exercise their rights. So again, the language clarifies the patient does not need to have been adjudged incompetent before their legal representative or their patient-selected representative can exercise the patient rights on behalf of the patient. So it clarified some of that. Again, this is going to hopefully get more clear. This looks a little muddy to me. It's going to get more clear when we get those interpretive guidelines out. Again, they have the having property and person treated with respect. They did change this other section here is to be free from verbal, mental, sexual, physical abuse, including injuries of unknown source, neglect, and misappropriation of property. Now, what this tells me, this is much more expansive than what we had before. We, as an agency, are going to be responsible for making sure we're checking this out. And I would recommend that on your visit note, you have some documentation or you have a checkbox that you use or something that says you've observed this patient for physical abuse or any kind of neglect for every single visit, because in the body of the comments and the responses from CMS, they were very clear that they want the home health agency to be watching these patients for any kind of abuse or neglect, and they want that to be reported to the proper authorities. Number 3 is make complaints to the agency regarding treatment and care that fails to be furnished and lack respect for property, very similar to what we had in the first, our old set. Participate in and be informed and consent to refuse care in advance of during treatment where appropriate in respect to the completion of all assessments. That includes physical, PT, OT, speech, and social worker at all time points. The care to be furnished based on the comprehensive assessment. Establishing and revising the plan of care, the disciplines that will furnish care, frequency of visits. Now, some of you have been exposed to surveyors who paid a lot of attention to frequency, some of you not so much, but I can tell you that they will be bringing their calendars with them from now on, and the frequency of visits is going to be a big deal. So you're going to have to make sure that on your plan of care that you're paying attention, that you have your frequency documented in a way they're going to easily understand. The expected outcomes for care, including patient-identified goals and anticipated risks and benefits, any factors that could impact treatment effectiveness, and any change in the care to be furnished. So all of this is they expect the patient to be included in all of this. So somehow we're going to have to document that the patient did participate in each one of these areas or their representative. Receive all services outlined on the plan of care. Now pay attention to that. Remember we talked a couple slides ago about the plan of care and not having these 6- and 7-page plan of cares any longer. Receive all services. This has become a patient right. That was not a patient right in the past. They just expected that to be done. But the surveyors, and most of the surveyors I've attended or I've been involved in, did not go into every single detail of the plan of care and make sure that you followed every single one of the points on the plan of care. This is saying that they expect all services outlined on the plan of care to be received. So you're going to have a very dynamic QA process. Again, your notes and your plan of care is going to have to be very specific, and the shorter the better. You're going to have to make sure that you have a plan of care that's doable and that's not cumbersome and it's easy to read and it's easy to follow. Have a confidential clinical record. Access to or release of patient information and clinical records is permitted, but they want to make sure that you have all your locked storage areas, and also good information to the patient, requiring that they keep their own information that's left in the home confidential as well. Be advised of the extent to which payment of services are expected from Medicare and Medicaid. As we go into this new health care plan, we don't know if we're going to get a 10% copay or not. It's going to be very important that you have specific information on your consent form indicating whether or not the patient is going to have any responsibility for payment for anything that's being included in home health. The charges for services that might not be covered, the charges the individual might have to pay before care is initiated, any charges in the information, any changes in the information provided in accordance to the above. When they occur, the agency must advise the patient representative of these changes in advance of the next home health visit. So it doesn't say before it happens, it says before the next home health visit, so they changed that a little bit. Receive proper notice in advance of specific services furnished that might not be covered. Be advised of the state toll-free hotline. Now, what they did here was they removed that section that indicated the advance directives. They really don't say a lot about advance directives in here. So you still have to get a copy of them, and you still have to ask about them. But if you remember, the definition for the toll-free hotline was to file complaints and also get information about advance directives. That's been taken out. Be advised of the names and addresses and phone numbers of all of these agencies. In the original, before the comments were received, they wanted us to provide very specific information for each patient. So for instance, if you had a patient with Parkinson's disease, you would be required to give them information on Parkinson's associations and support groups and that kind of thing. They took that out, and so what they are saying is they want specific contact information in the start of care packets or in patient packets for these particular entities. Be free from any discrimination or reprisal for exercising the rights or voicing grievances. Be informed of the right to have access to auxiliary aids and language services. And again, you can have interpreters and you can get outside language services to help you out if you need that. The timing and delivery rights varies depending on who's receiving it. Like I mentioned before, whether it's a legal representative or the patient selected representative. The patient may choose to decline the provision of patient rights to the patient selected representative. CMS indicates the patient may determine the role of the representative to the extent possible. And the agency needs to, and they highlighted that, document the patient decisions. So you may need to have a separate form, a patient representative form that indicates exactly what kind of information a patient-selected representative can have, what kinds of information the legal representative can have. Here's the table that I put together for you that indicates the type of the rights document, who would receive it, and what the time frame is in getting that information to that particular receiver. The agency can use technology or remote interpretation services. Again, selected interpreters for translation. They've allowed the agency additional time to provide the oral notification of rights, so that if you can't, that's why they gave us that by the next visit to give the oral rights in case there's no one to interpret for us if we don't have what we need at the time we do our initial assessment. That gives you a little bit of time to access any kind of technology or any interpreters that you might need. The patient's family member or friend can serve as liaison between the patient and the agency. The legal and patient identified representative can help the patient communicate with the agency and explain instructions that you provide. You will need to identify the differences, again, between the legal representative and the patient representative. The agency has reason to pay attention to this because this is important, and I'm not sure what they're going to do to enforce this, but if the agency has reason to believe the representative is not functioning or making decisions in the best interest of the patient or could cause harm or cannot perform the functions necessary, it's the responsibility of the agency to make referrals and reports to authorities. Now, this says a lot without being very direct and telling us what they mean by this, but my assumption would be is if you have a representative who is just not following through, they're not showing up to set up their meds, they're just not following through with things, it's going to be on our responsibility to make sure that we're reporting that and we're correcting the situation. So you're going to have to do a lot of review with the patient when you go in for every single one of your visits to make sure the plan is being followed the way you expect it to be and the way you have it set up. And you're going to have the documentation that shows that you are following up on this. You will need to provide notice of the availability of assistance, whether or not you communicate with the representatives or patients. Patients may have their own interpreters. The notice of availability, it looks to me and to others that it's going to be the agency's responsibility to make a list of caregivers and the times that they're available, whether they're working or not, and what they're able to provide for the patient. So it's going to be something different than what we have in our OASIS right now, but that's going to have to be part of our assessment. Again, the administrator contact information, there's quite a few changes there. We have to have all that contact information for them. Additional information, again, that consumer information that in advocacy agencies, I gave you the list of copies of policies, your admission policies, transfer and discharge policies. The patient or caregiver will have influence on whether or not you discharge your patient. So that's why you have to make sure that you spend time and a lot of effort and thought into creating your discharge policies and making sure you're covered everything. They don't talk a lot about, they were very vague in the way they indicated reasons for discharge, so that if you have an unsafe situation, there's not a lot of good information in the responses and the comments that we've received on the new patient, on the new conditions, as to how you handle that situation. So we're hoping that the conditions will give us more information, but the safety of the staff is not very specific in this whole set of rights. So your surveyors, again, are going to want to review the changes that you've made in your admission packet, in your patient rights in general, and your policies. They're going to scrutinize your policies. This is going to be something like we've never experienced before. They're going to be looking at everything in our policies to make sure that we've made the changes that are necessary. During the home visits, they're going to ask the patients whether they were made aware of their rights. They're probably going to even ask about time frames. If you have the patient representative there, they're going to ask them questions. Make sure all your patients can answer questions about their plan of care, including your disciplines. Your visit frequency is going to be very, very important, and I know many agencies, many agencies have gotten away from leaving schedules in the home. It will be a priority for you to do this now. You'll have to have a schedule in the home, making sure that the patient's aware of what the frequencies are, how to file complaints, and again, making sure that they receive all the ordered services on the plan of care. Some tips that I have for you is to make sure that you assess the cognitive ability. There's a whole section that requires that we do a cognitive assessment. It's more than just the PHQ-2 that we do on OASIS. They want a whole cognitive assessment done on your patient. They don't tell you what form they need you to use or they want you to use, but it will be up to you to do a cognitive assessment, and that they will look at that to see if it makes sense that the patient is understanding their rights the way you say they do, and the way they sign off on indicating that they do are related to that cognitive assessment. Here's a translation. You need to have your patients sign that they understand the rights, but this NOC has given us a place where we can call for interpretation services. Spend several minutes during the admission talking with your patient about the rights. You might need to spend more time every single visit reviewing rights. I would highly recommend that you review your rights every visit. They clarified that all complaints have to be investigated. So my recommendation to you is to have a complaint log and that no matter how simple the complaint is to get that complaint logged in, make sure that all of your staff understand how to do this, and follow through so that the surveyor, when they come, can see that you follow all the complaints, no matter how trivial you may think they are. It's better to have information in your complaint log and that shows that you're compliant with the process as opposed to not having anything. Also in 44.50C13, the language has been enhanced to make it clear the agency needs to take steps to prevent retaliation against the complainant. Everyone in the agency, including your contractors, now pay attention to this because your contracts are going to have to change too. You're going to have to put language in your contracts that makes sure that these contractors are following through. Everyone in the agency has to report to the agency administrator regarding incidences of mistreatment, neglect, abuse, or misappropriation of the patient's property. And so this is that area I told you that you're going to have to have some kind of either a document, some kind of form that you complete to say that you did review these areas for the patient and that you find no problems there. So again, interpretive guidelines will be very helpful for us. Your transfer and discharge, they're specific about time frames, and I know that we've had the responsibility to get transfer and discharge information to the transferring entity. However, it hasn't been followed the best in agencies that I've been in, so this requirement at 44.50D specifies what we need to the time frames that this needs to occur. So the patient and the representative have to be informed of the agency's policies on transfer and discharge. I mentioned to you that you have to have a copy of that in your start of care packet. The agency may only transfer the patient if the transfer is necessary for the patient's welfare because of the agency and the physician who's responsible for the agency plan of care agree. If the agency can no longer meet the patient needs based on the patient's acuity, the agency must arrange a safe and appropriate transfer to other entities when the needs of the patient exceed the agency's capabilities. Now, what they also said was they expect you to assess that patient at intake to make sure that you can care for the patient so that this doesn't necessarily have to occur, but you're going to have to be careful that your policies have all these indicators in them, and they also recommended that and they weren't as clear in the final responses in here, but in the original set of conditions, they indicated that they would expect the agency who's referring to another entity to be looking at the quality of care that that other entity is providing. So for instance, if you're transferring a patient to a hospice, that you would look up the star ratings and get information about that hospice before you give the information to the patient. The patient payer will no longer pay for the services provided to the agency is another reason for transfer or discharge. The transfer or discharge is appropriate because the physician who's responsible for the agency agreed that measurable outcomes and goals set forth in the plan of care have been achieved, and that the agency and the physician who's responsible for the home health plan of care agree that the patient no longer needs the agency services. The patient refuses services or elects to be discharged or transferred. The agency determines under the policy set forth by the agency the purpose of addressing the discharge for the cause that meets the requirements, that the patient or other persons in the patient's home behavior is disruptive, abusive, or uncooperative, or extended delivery of care to the patient refuses to be transferred to another agency, the agency has to continue. So this is unclear too. And I was listening to Bill Dombey speak about this. This is one of the areas that NOC's working on with CMS to try to get it clarified, because it actually looks as though if the patient absolutely refuses to be transferred, even though there's good reason for it, that the patient doesn't have to be transferred. The agency is going to have to continue to see that patient. The patient or the ability of the agency is seriously impaired. The patient or the ability of the home health agency to operate effectively is seriously impaired. The agency must do the following before it discharges the patient for cause. They have to advise the patient and their representative of the discharge and the cause, make efforts to resolve any kind of problem that presented the patient's behavior or the behavior of other persons in the patient's home or situation, provide the patient representative with contact information for other agencies that can provide the care, and document the problem in efforts to resolve the problem. Now, I certainly, if you ran into something like this, you would want to get a social worker involved. So this all has to do with not being able to care for that patient adequately as an agency. The other two reasons they give us for being able to discharge is patient death and or if the agency ceases to operate. So my tips for you as far as compliance for this, if the patient's being discharged from the hospital, you need to document the patient's risk for emergency room visits and rehospitalization. Transfer deadlines and transfer summaries have to be submitted to that discharge entity within 2 business days. Discharge summaries have to be submitted within 5 business days. CMS wants to see it faster. They would like to see it in 2 calendar days. So we would incorporate the interdisciplinary team approach to provide home health services. Begin working on a process for hitting these deadlines. This is not going to be an easy task to accomplish. We're going to have certain information in our transfer and discharge documents that go to the other entity that might include things like current labs, medications, and that kind of thing. In an effort to reduce and eliminate silos of care, new language in the CMS indicates the need for agencies to work closely with the physicians and other entities in the patient circle of care. So we want to make sure that all of these deadlines are hit and that everybody's communicating the same information about that patient so that the patient doesn't have any lapses in care. So 484.55 has to do with the comprehensive assessment. They did make some changes. Most of the original language is left in. They did reorganize information about OASIS. Each patient has to receive a patient-specific comprehensive assessment. That was clarified. They added a new standard content of the comprehensive assessment, incorporating the drug regimen review, OASIS data items, assessment, psychological and cognitive status. And remember, I told you that they want us to do a cognitive assessment, so that's part of that. The following information or following items have to be included: the patient's current health, psychosocial, this is new, functional, cognitive status, patient strengths, goals, and care preferences will have to be documented, including the patient's progress toward achievement of goals identified by the patient and the measurable outcome identified by the agency, which is new. So I've been recommending to agencies that on their plan of care, probably just after box 21, when you have the goals, that you would actually write something very specific that says patient's goals for this episode of care and document exactly what the patient said. So let's say, for instance, the patient, you ask the patient what their goal is, and the patient said, well, I would like to walk to the mailbox. The patient has had a massive CVA, and you know that ambulation is not going to be part of much of what you're going to be able to accomplish in a 60-day period, and that walking to the mailbox may not be possible, but just a minute, please. Our building's being evacuated. Well, I'm going to get through this for you, and we're having a very bad windstorm here, so I hear things banging on the ceiling. I'm not sure if something's going to fall on me, but anyway, the patient's strengths, goals, and care preferences, including the patient's progress toward achievement of goals, identify the patient measurable outcomes by the agency. Those are all new, and so you're going to have to make sure that those are well documented. So let me go back to the example I was trying to give you, I'm sorry, of the mailbox. So if the patient's not able to reach that goal, there would be documentation in the assessment indicating that you explained to the patient why that goal could not be met, and that you would work on something toward that goal, but perhaps that wouldn't be met. So then you would try to assist the patient in coming up with a goal that would make sense. Again, the patient's continuing need for home care would have to be documented. That wasn't real specific in our last set of conditions. So you'll have to make sure that occasionally you're right, even though we're not doing 60-day summaries any longer, you will be writing some kind of analysis as to why that patient has to continue with home health care. The patient's medical, nursing, rehab, social, and discharge planning needs would have to be documented. A review of the medications currently taking, patient's primary caregivers, patient's representative, that should all be included in your assessment. It's required that the assessment also incorporate items from the OASIS. So in addition to the above information, they've added patient ordered resumption of care date, and they, instead of, so that we have 48 hours, we have 24 hours to get out to see the patient within, I'm sorry, 48 hours to see the patient after a hospitalization. So what they've given us is a terminology that says physician ordered resumption of start of care date. So it's very similar to the start of care, physician ordered start of care date, so that we're not locked into that 48-hour time frame. They want us to use standardized tests and measures. That's always been understood but not always practiced. So it would be important for you to start looking for standardized tests and measures in assessing a patient's psycho and social status. Refers to an evaluation of his or her mental health status, social status, and functional capability. There are standardized forms available online that actually have calculation where you can actually have a numbered scoring system for patients to get a cognitive assessment. Intended to be a screening for potential issues that may complicate or interfere with delivery of service and the patient's ability to engage in care. So what they're saying here is they're really going to be paying attention to how well you're documenting the patient's cognitive status and whether or not you are engaging in practices and following through with their plan of care that is appropriate for that particular patient. So if you have, for instance, if on your plan of care you're saying you're going to teach all current medications to the patient's on 15 medications, and the patient has cognitive problems, that's probably not going to happen with that patient. So the surveyor is going to be looking very carefully at how the agency is assessing the patient, and then how they're following through with indicators on their plan of care. CMS, again, wants a cognitive assessment to be part of the routine practice, so their goal here is to enable the agencies to develop more complete and patient-centered understanding of the patient and developing a plan of care. They're trying to take the patient out of a passive role. They feel that if a patient's more engaged in actually putting their plan of care together and attempting to reach goals, they will be more likely to follow through with things. So you want to evaluate the patient can do. So for instance, if the patient really understands their medications when you go in there, that might not be something you need to spend time on, but you're going to have to document those types of things. They're going to have to document on your comprehensive assessment. So many of your comprehensive assessments are going to have to change. You're going to have to add indicators in there that will be reminders for your staff to make sure they get that documented. So expect agencies to evaluate the strengths and weaknesses of the patient. They need to identify care preferences to accommodate the patient. That needs to be documented. So they want, CMS is trying to assure the agency plan for and provide care that is both patient-directed in accordance to the physician's plan of care. The response from CMS is that the requirement for all patients, not just those receiving skilled care. So the way it looks right now is they're saying that even if you, many times agencies look at the conditions of participation as Medicare only. And what CMS is saying, this isn't just for Medicare, this is for all your patients you're seeing. You're certified under a program, they expect you to follow through with this on all of your patients. So it's designed, the changes in the comprehensive assessment is designed to identify needs, again, of the unique patient. If you can't complete the assessment in 5 days, don't accept the referral, and they were very clear about that. So I believe the surveyors, too, are going to look to see if agencies are just accepting referrals just because they want the referral, or if they're accepting the referrals because they can actually take care of the patient. You need to gather information about the caregivers. Again, this is that document I mentioned to you earlier. Have something that shows the willingness to carry out the necessary tasks, their ability to carry out the tasks, their availability, and their schedules. And so this is, again, very subjective information they expect you to have documented in your comprehensive assessment. So again, that's going to be a change that vendors are going to have to be paying attention to. Your surveyors are going to review your entire assessment for compliance with this rule. We recommend that you make changes easy for the surveyor to find areas of compliance in the documentation. Surveyors are going to scrutinize integrated assessments. They don't want to see copy and paste any longer. So your nurses and your therapists that are used to checking off boxes and sending them in just so they can get a paycheck, that time is long gone. They really need to be doing unique assessments and unique plans of care. The surveyors will ask patients questions, again, about their active participation in the program. That would be something I would highly encourage you to talk to your patient about as you're doing your assessment and as you're doing your discharge, to let them know, make them feel as though they actually did have active participation in the program. My recommendations for you is to make sure you start training immediately on your comprehensive assessment changes. Do some research, gather tools for complying with the rule at Quality in Real Time. I'm sure we have tools that will be available for this. Use educational documents to support education of your caregiver and patient. Create a patient preference tool. I don't know that we have one of those available to you, but you can probably do one of those, so that it's going to be pretty simple. Just a list of what the patient prefers during your episode time frame and how you're going to comply with that, and again, gathering your tools for tests and measures. So 484.60, some of these kind of overlap, and you're going to see that. Care planning, coordination of services, and quality of care delivered. There's a lot of information in here, a ton of information. And again, until we get the interpretive guidelines, we're just going to have to do the best we can to comply with this. So again, on the plan of care, the one thing they point out is they want an individualized patient plan of care. The plan of care has to include patient caregiver education and training to facilitate timely discharge. What are you going to teach? How long is it going to take you to teach? You don't have to teach every visit. That's a whole session that would be separate from this. But your plan of care really, really has to get whittled down. It has to be specific. It has to be unique to that patient. You can no longer use pre-printed plans of care. Your EMR, the worksheets they have and the worksheets they have in the summary of your plan of care in the EMR are just recommendations. If you know that something needs to be added to your documentation for the plan of care, you need to do that. You can't use your electronic medical record as an excuse any longer, and the surveyors aren't going to take them as excuses. So each plan of care has to be individualized, and the documentation has to be specific to every single patient. They're going to be looking for conformance with physician's orders. Immunizations is a big deal. They want to make sure that we have documentation of all of the immunizations, when they had them, what they had. Your orders, as far as conforming with physician orders, for the clinical staff, this is not the doctor, but for the original plan, a set of conditions included that the doctor had to include the time that they when they signed the orders. That's not in there any longer. This is just for the clinicians. So when a verbal order is taken, if an order is documented, the clinician needs to include the time the orders were received. Now, this isn't any different than we did when we worked in hospitals and nursing homes. So the gasps that you hear from staff when you tell them they have to do that shouldn't be there, because we know that that's the legal way to write orders to begin with. So again, the orders have to be documented, signed, and the time the orders were received would be included in any kind of change orders. The review and revision of the plan of care, the revisions regarding the plans for discharge have to be communicated with the patient representative, caregiver, and the physician practitioner who's going to be responsible for the care after the discharge. So anything that's revised, there has to be clear indication that doctor has been notified at the time of that notification. In this whole condition, they also include coordination of care, again, integration of services, and it's not just the team that's in your agency. You need to be paying attention to all those other services the patient's getting. Could be chemo, could be it could be dialysis, wound care clinics, and then your discharge and transfer summary information that we talked about earlier in the previous section is included again in the care planning, coordination, and quality of care delivered. So my tips for success for you would be provide a copy of the plan of care. Now, this is not required. They did require that in the original set of plans, the original set of conditions. That's not required now, but it's not a bad idea. It's really kind of nice if the patient goes to the emergency room when an agency staff member is not there, to have a copy of their plan of care that they can take with them, so that the emergency room or the hospital or the transferring entity will have a copy of the most current information about that patient. The plan of care must indicate the risk for rehospitalization. They do not want us to use the terms low, medium, high. We're either going to have scoring or something that indicates that patient's risk for rehospitalization, and specific documentation in the clinical record. Provide the patient-specific goals and patient-specific measurable outcomes that the agency expects. And again, I mentioned this to you before, that if the patients take an active part in their decision-making, they're more likely to follow through. So you want to make sure that you have not only the clinician written goals are patient-specific, but that you also have goals that the patient actually has for themselves. Again, your verbal orders, we've already reviewed that. They did also indicate they were specifically made mention of LPNs and LVNs being able to take verbal orders. That's never been in the conditions in the past, and it's always a question. And you would have to, and that's okay to have that in there, but also check with your state, because if there's a problem there, you're going to have to follow your state rules. Although the federal rules say that we can, the state rules may override that. So the surveyor is going to be looking at your transition policies, how the transition toward patient outcome-based system, and your transition into with other entities when they're discharged from your agency, coordination of care between all services being provided to the patient, looking for patient-centered care that's outcome-focused, looking for a detailed plan of care, and a copy of the plan of care and change orders left in the home. Again, that is my recommendation. I believe the surveyors may look for that, but probably not. So you don't have to leave the plan of care in the home. Paying more attention to the specificity of the individualization of the plan of care, and making sure that every single thing on that plan of care is taken care of by the time you discharge. Your QAPI 484.65, again, many of you may already have a QAPI program. You just want to make sure the due date for this is January 13th. Now, this is just for QAPI. The new, this has replaced the PAC, at least that's what they say. The part of the overall quality focus is an effort to reduce medical errors and improve quality of care in all care settings. CMS estimates in 1 year the agency will spend about 81 hours annually on QAPI, and that might be reduced to 75 hours annually afterwards. That's probably not a good projection. We believe that most of the experts that I've spoken with believe that it's going to take much more time than that. You're likely going to have a full-time person assigned to this job responsibility. So the QAPI program is divided into 5 standards: the program scope, the program data, activities, performance improvement, and executive responsibilities. And this is where the whole issue with the board of directors lies. And there's a whole new area that in these conditions that outline exactly what the board's responsibilities are. The quality assessment performance improvement, again, is much like Joint Commission. So if you're Joint Commission accredited or any of the other accreditation bodies that require QAPI, you may be okay, but make sure that you double check and make sure that you're covering everything that the conditions require you to cover. Agencies have to create data-driven goals and evidence-based performance improvement programs of your own design. Pay attention to that, because they've been, again, very specific in many areas in these conditions, talking about your own design within the agency, that it's not only unique to the patient but also unique to the agency. The agency is going to be expected to measure, analyze, and track quality indicators that would include your adverse events, performance of processes, services, and operations, focusing on high risk, high volume, and problem-prone areas of service to consider the incidence, prevalence, and severity of problems in those areas. So for instance, you'd be tracking like your any kind of incidents that were going on, complaints related to a particular staff member perhaps. Your infection control would be rolled into there, so you might be tracking infections and maybe relating to specific staff members. Your data collection review has to include indicators showing improvement. Measurable improvement has to be documented. Establishment of the patient's ability to sustain individual goals. And then the focus should be on high priority safety and health conditions and other goals specified by the agency. So your QAPI program will be designed for you. So you may have goals, certainly goals in Massachusetts are going to be different than goals in agencies in San Francisco, California. So you're not going to be able to, they don't want to see us, you know, we can share information for structure, but they don't want us to be duplicating, making copies of our quality programs from agency to agency. They want to make sure that you take into consideration, your board takes into consideration what's unique about your agency and what actions need to be taken to have a qualified QAPI program. So again, here's your board of directors. So the board's going to be responsible to make sure there's an ongoing proper quality program, QAPI program going on that's defined, it's implemented, maintained. The QAPI program addresses priorities for improved quality of care, patient safety, and improvement actions, and they're evaluated for their effectiveness. There's clear expectations for patient safety that are established, implemented, and maintained. Any fraud, waste, and abuse would be looked at by the QAPI program and appropriately addressed. And programs data standards requires the board approves the frequency and the detail of the agency's data collection. So in there, you would want to include things like, for instance, looking at your CASPR programs, looking at your PEPR reports. All of that would be included, and your board of directors is going to be responsible for all of this. In the past, the board was only responsible for making sure we had policies and procedures and we had the right administrative staff involved, and you had minutes to your meetings. But now they're going to be looking for evidence that your board is taking an active role in this QAPI program. So you're going to have some type of minutes, some type of documentation showing the active involvement of your board of directors in your QAPI program. So the surveyor, again, is going to evaluate the process. They're going to be looking for clear documentation as to how compliance is achieved. They're going to look for performance improvement that's conducted at least annually. They're going to look at reports that show the scope of services, complexity, and any kind of past performance and what you've done to improve it. Infection control, they want you to, again, this is a separate condition, but again, the process itself can be rolled into QAPI. So they want you to be following standards of practice, and like I said, you want to make sure that you're looking at CDC policies on an ongoing basis. So your infection control manager or your QAPI manager would be responsible for that. You want to make sure you have a formal infection control program that covers prevention, control, and education of patients' family members. you should have, at a minimum, identify an infectious and communicable disease problems and a plan for appropriate actions if you have a problem that occurs. Maintain an agency-wide program to survey, identify, prevent, control, investigate infections and communicable diseases. You don't have to have a special committee, but you do have to have somebody who's responsible for getting this data together. And some things that you could use for an example would be UTIs, soft tissue infections, central line associated blood infections, and that kind of thing. Again, hand washing is so important, and making sure that you have hand washing techniques outlined for your staff, and possibly do a quarterly employee group and watch them wash their hands. And there's some little kits that you can buy that you actually use black lights to see if they've left things on their hands. Inquire the use of antibiotics, why the patient's on an antibiotic, making sure that you're identifying and preventing any kind of disease outbreaks. Track if a patient or a clinician in your agency suddenly comes down with an unexplained illness. Make sure that you're communicating between each other, and you might have a call line into a QAPI manager when your clinicians are exposed to anything, or if they come down with any kind of infectious diseases. Again, they recommend that you identify an infection control manager. It's likely to be an RN, it doesn't have to be, but somebody who has some kind of infection control experience, and they would be the ones collecting all the reports and the data and issuing the reports to the board. The QAPI staff would need to spend as much as a third of their time, if they have infection control included, they would be expected to take up about a third of their time just managing that infection control program. So the surveyors are going to expect the agencies to work with your local health departments, find out what kind of outbreaks are going on in your communities, looking for policies, procedures, and practices indicating prevention, education, and control. Those are 3 areas they'll look for. The surveyors will scrutinize your policies and procedures related to your infection control program. For agencies who already have programs, you can compare them with what these new conditions are requiring and making sure that you're compliant. The last thing I think we're going to talk about here is skilled professional services. Rather than to have the 3 sections where they had skilled nursing, skilled therapy, and social worker, they've included them as skilled professional services. So you don't have those 3 separate indicators. And this is just a list of the things that they would expect. So a lot of this is going to have to be changes in your, most of this is going to have to be a change in your job descriptions. So the one big change in here, of course, is that you've got the QAPI program involvement, that all of your professional services have some kind of involvement in. Again, they also outline the supervision. So if it's nursing, it's got to be supervised by an RN. If it's rehab, it's got to be supervised by the appropriate therapist. And then if it's social worker. Your home health aide training has changed quite a bit. I encourage you to pull this out and read it very, very carefully. They've added recognizing and reporting skin conditions. We've not done that in the past with our home health aides. They are allowing CNA training certificates for qualification for the training. They have not done that in the past. Infection prevention was added, not just control. So you're going to have to do a revamping of your assessment processes of your new aides and their competency to include infection prevention. Recognizing emergencies and knowledge of instituting emergency procedures and application. Again, that will have to be added to competency, and I would recommend that you actually do maybe some mock emergencies and see how every single one of the aides respond to those emergencies. Other aid changes, again, would be instruction on changes with communication skills, that they have to have the ability to read, write, and verbally report clinical information. That was added. Your infection prevention, recognizing emergencies, reporting changes in skin condition, and the assignments that they're done by the appropriate skilled professional. That It doesn't have to be a aide supervisor, but it has to be done by, if it's a therapy case that the aide is working on, then the therapist should be the one who's making the changes on the assignments. So even if you have, again, this has to do with your infection control program, this is just make sure that you're following the same one, that and that the aides are understanding your infection control policy in the conditions, if they're, and make sure they're the same as what you're using if you're accredited by another body. Your QAPI staff, make sure that your QAPI staff checks every day or week to alert clinicians of new outbreaks. Again, watching that CDC website. They've done a very nice job in the last number of years of improving that CDC website. It's easier to follow, it's easier to read. So make sure that you're looking for communicable diseases like MRSA or other or strains of tuberculosis. My grandson just took a trip to Costa Rica and was notified just this week that he had been exposed to TB, so that's still a prevalent kind of thing going on. Your QAPI staff needs to educate your clinicians on standard precautions, monitoring field observations. Here's some websites that I would recommend you look at regarding QAPI or infection control that will help you put your program together. We recommend that you assign someone to quality management. Agencies will require assigning a staff member with increased quality improvement responsibilities. The quality improvement person will track outcomes such as patient characteristics, discharge summaries, potentially avoidable events and hospital readmissions. Much of this you'll get off of CASPR. Again, I would encourage you to include in your QAPI program your PEPR analysis from your PEPR reports. The type of data related to quality improvement projects, again, would be from CASPR. Agencies would need to propose ways to reverse undesirable outcomes, like high admission rates, educate clinicians on how to do that, and how to document things, not just improvements, but there's a sustaining of the improvement, and teaching staff members how to document sustained improvement would be important as part of your goals for your quality program. Some of this information I got from Bob Marquette, a home health attorney. Review current QAPI efforts to identify the components that can be utilized in the efforts to prepare for an individual QAPI program. I know that Quality in Real Time has a QAPI program that they are going to be rolling out that agencies will be able to use as an outline for themselves. We recommend that you educate your board of directors, start educating them immediately. Begin to consider how to connect the board of directors, how you're going to document that to show the surveyor that you do have a direct connection between your quality improvement program and the board. And again, start looking at your different reports that you already have available. So that was a lot of information. So in summary, agencies that have not assigned quality managers to monitor outcomes and trends, such as infections, are going to have to begin doing so in order to meet these QAPI requirements. Significant concern about the use of the word must throughout the conditions. Whenever you see a government document that says must, just that one word says that they're going to be looking for that. Then you have to comply with that. That's different than may. The word must is found throughout these new conditions, so you're going to have to pay attention, make sure that you are able to indicate compliance. It's likely to cause increased citations. Like I said before, I would expect to see more sanctions given as a result of these surveys. There's dramatic administrative burdens. You really need to start working on this immediately. Agencies need a significantly higher degree of sophistication in managing. Again, we're going to be looking, we need to start functioning more like institutions as opposed to home care agencies that have a few rooms that they've rented out to do a nice little business. It's expected that the mediocre agency will likely not have what it takes to weather this. This certainly is a perfect storm with everything we have coming at us. In Massachusetts, you're along the same road as Florida and Illinois now with PCR, so you've got that to contend with too once you get the word that that's going to start. in your value-based purchasing as well. Surveyors are going to be working with accrediting bodies, are likely to need less training. State and federal surveyors, I mentioned that before because a lot of this, the clopping, the infection control is just part of what they do all the time. So in light of sanctions now in place, again, it's not known how the surveyor is going to react. I would expect there's going to be a learning curve. I think they're going to err on the side of caution for the most part, and they're probably going to be issuing more citations than they may maybe 5 years down the road. So some believe the transition for the new conditions will be more difficult for CMS than for agencies. If the agency is accredited, again, some of this will be just review of your policies and processes and making sure that you are compliant with the new conditions. I've given you a number of references here that you can look up some of the information I've given you. These are helpful references for you in putting together policies and procedures for yourself. I wanted to let you know, and I'm going to send Monica the information. I'm doing, Bob Marquette and I actually are doing a boot camp for the conditions. It'll be a 1 full day in Philadelphia and Chicago. And then if you watch your website, and I'm sure that Quality in Real Time will give Monica the information, Quality in Real Time is in the process of planning a 2-day, very intense training program for these conditions. So that might be something else if you'd like to get away from the office for a couple days that that will be very, very helpful for you. And we're going to take each one of these conditions and pull them apart and show you exactly what you need to do to get ready for your next survey. So Monica, I think with that, if you have any questions and people want to stay on the line, I'm going to stay here and walk through any of the questions you might have.
Great. Okay, so the one question that I had just recently was asking if you'll get a copy of the audio for the webinar because there's so much information. They want to refer back to the clarifications with the changes. So I can answer that. Yes, you will receive a recording of this webinar as well as the handouts again. I will resend everything out that was sent before. Once it's processed, I'll send it out. So I'll probably send it out by tomorrow morning just because sometimes it takes a little bit longer, especially with a webinar longer like this. Now, for questions that I can't answer, the first one we had was, can a clinical manager be an LPN?
No. No, that's very clear. No, it cannot. Okay. It has to be a registered nurse or a physician.
All right, perfect. And also, while I'm reading any of these questions, as a reminder, if you have some, please do so now. I'm sure that anything that you have to ask someone else has the same question, so you can write it in the questions tab in the sidebar of the webinar screen that you have. But the next question that we have is on slide 18, you've listed RN or MD for clinical manager. I thought the language says PT, OT speech, and audiology as well.
No, no, those are qualifying. I'll take a look at that. I can get back with you, Monica. And do you have the contact information for that person?
Yes, I do.
Okay. Okay. Slide 18.
Correct. Yeah.
Okay.
Now, at the moment, that's all we have. So again, if people have questions, there's a question tab, or if you find the chat one, you can type it in there as well. Okay, so what do you mean by no 60-day summary needed anymore? Research OASIS 2.
Well, you still have to do research OASIS. The need for the 60-day summary that we do now has been taken out for the new conditions. But for all of this, the agency should be very careful not to stop their current practice until that July 13th date. But as of July 13th, the 60-day summary will no longer be required. But the OASIS research certainly are required.
Okay, great. Is transfer referencing transferring patient to another agency or to emergent care?
Any transfer, any type of transfer at all. an entity and that information. So you will have to give a summary of what's going on, what has gone on during the episode to that entity that the patient's being transferred to. It could be hospice, it could be a nursing home, it could be a hospital. Any entity that the patient's being transferred to would receive that information.
Okay. What was it you said regarding DME and providing choice?
DME and providing choice. I don't remember mentioning that at all, but I mean, we have to provide choice to patients. If they, that would be one of those involvement of the patient questions that you would ask. What DME would they prefer? And you would include that on the plan of care, that was patient preference. So yeah, in that, your patient remember I mentioned that maybe they would want to prepare a patient preference document, and that would be one of those things. Well, what DME do you prefer that we use, and that kind of thing.
Okay. Any update on change from 60-day episode to a 30-day episode?
Oh, well, yes, that has nothing to do with the conditions, but yes, that's something that will be, we were told is going to happen I'll quote, this summer. There's not a date. That is part of another study that was done and a result of recommendations by that study. And yes, it will be 30-day episodes, and it will be the therapy add-on, the case mix points for therapies will be taken away during the summer, but they haven't said when, so it could be, beginning of the fall, who knows, but that's another thing we have to watch out for, but that is completely separate from the conditions. That's a compliance issue.
Yeah. Okay. There is a statement about not using agency equipment to substitute for patient equipment for POC testing. Does this include CoaguCheck? And it looks like she added.
Well, I don't have any information on that. I would have to, if that's a specific question someone wants me to check on, I'll do that. That's not. Yes, there is some information in there about like not using the patient's glucometers and that kind of thing. So if they have a specific question, if you want to email that to me, Megan, I'll make sure that I respond to it. Mm-hmm.
All right, will do. For Medicare clients, we are only contracted with Medline. Would we have to get contracts with other DME companies, or is it that only for insurance orders or private pay?
I'm not that familiar with those types of contracts. I wouldn't expect the surveyor to be, there's nothing specific in there about contracts with DME companies in the conditions at all. So I think that would be something more that would be something to ask your attorney than probably, it's not part of the conditions.
Okay.
That might give me that question though in an email, Megan, and I'll respond to it.
Sure thing. Next one is all the QAPI changes truly pushed out to 2018?
Not all of them, and I don't have in front of me a specific list of which ones are. You've got to have your program together. It's the data that's going to be pushed out to the 2018 date. So we'll cover that in some more intense condition training. But no, thank you for asking that though, because that's a real muddy part of this. It's not real clear exactly what they're going to expect to have done now and what they'll expect to have done later. I'm sure that the conditions are going to, the interpretive guidelines are going to outline that for us very well so that we'll have more information on exactly what they expect to see on that July 13th date and what can be pushed out. I'm sure it's the analysis of the data that's being pushed out, but not the entire QAPI program. The QAPI, you'll have to have a program in place that you'll be working on, but they won't expect to see data when they walk in the door.
Okay. Can the agency use our own equipment to trial with a patient prior to purchasing one for them?
Say that again.
Can an agency use their own equipment to trial with a patient prior to purchasing one for them?
Well, the agency can't purchase anything for the agency can't purchase anything for the patient, so I'm not sure what they're referring to. If the patient's using something, I would need more information on what they're asking, but I just want to be clear that there's no point at any time during an admission that you can purchase anything for an agent or for a patient, unless you're hospice. I mean, the hospice is different. But
okay. Do we have any other questions? And while I'm waiting for any last-minute ones, as a reminder, once again, this was recorded. It'll be sent out most likely by tomorrow morning at the latest, and that will include the handouts as well. So you're welcome to have your staff listen to it or anything. This was a member benefit for the Home Care Alliance. So for those of you who are members, you have full access to the recording. You can send it to any of your other staff free of charge. So I appreciate you all calling in today. And Arlene, thank you very much for your time with this webinar. I really appreciate it.
well, thank you.
I hope to see more of you, more of our webinars and on-site programs. Oh, sorry, we have one more question. Do you have a rehospitalization risk criteria with numbers versus low, med, high? Oh, medium, high, maybe?
You know, I don't, but, you know, I will talk to the staff at Quality and Real Time and see if there's something that they may have available. Since they do coding, they may have tools that they use internally that I'm not aware of. But again, if you want to put that in your email to me, Monica, I will double check on that and let them know. And some of those references those references at the end of the slides, there may be information included in some of those references as well.
All right, perfect. Well, thank you again for your time, and thank you all for calling in. And with that, have a great rest of your day.